new lectures depicted the topic which entitled osteoarthritis, osteoarthritis, and rheumatoid arthritis. They are the most common clinical conditions that occur the scientific interest worldwide. So first of all, let's concentrate on osteoarthritis, and then in 40 minutes, we'll switch to rheumatoid arthritis till the end of our lecture course. So, osteoarthritis has been considered degenerative joint disease. The definition is considered to be the most important primary degenerative joint disease. The current concept holds that these conditions involve the entire joint organs, including the subchondral bones, nerve, soft tissue located around the joints. And finally, the definition of osteoarthritis summarized both joint structure and around the joint structure. Next slide, you can see the frequency that occurs osteoarthritis worldwide. There is no point in arguing that osteoarthritis is the most common clinical condition that occurs frequently in individuals older than 64 years old, and estimated for around different populations. By the way, the elder and the senior people are defined as a target population in which we can see the increased dramatic frequency of osteoarthritis as well. So that finally the frequency and the occurrence of osteoarthritis is closely dependent on this signature of the metabolic conditions and the profile of the other diseases communicated with the risk of osteoarthritis. Finally, we have a great opportunity to talk about the proof of the link between the osteoarthritis and the clinical conditions, the people having the high risk of the onset of them, and predispositions, including genes predisposition with some aggravating comorbidities factors communicated with the osteoarthritis. Next slide depicts mortality and morbidity. It's extremely important to know that disease progression globally characterized as a slow, acute, severe years and decade. During the last 2 decades, we know absolutely that disease progression is dependent on the risk, the onset of degenerative joint consequences, which in turn overstrating with metabolic condition, including diabetes mellitus, mainly type 2 diabetes mellitus, abdominal obesity, and the morbid obesity, and the insulin resistance as well. So this progression being identified as the mounting up and the new characteristics of joint degenerative proof as occurred with periarticular complications. So, and finally, the first common clinical sign is defined as the pain. And the pain is usually the initial, the principal source of morbidity of osteoarthritis. The next situation is referred to inflammatory changes that frequently occur in these patients beyond all pain as well. So, taking into consideration that the people having the high risk of disease progression due to established osteoarthritis can be defined as the senior, and these people also might be speculated as having the high risk of cardiovascular complications associated with accelerating atherosclerosis and osteoporosis, and the whole risk of potential life-threatening fatal complications, something like stroke, transient ischemic attack, heart failure, acute coronary syndrome, and the stable angina, and so on. And finally, that is a profile of life-threatening complications may be seen in the patients in connection with the risk of the plaque instability. Indeed, the patient has high mortality and morbidity rate associated with the progression of osteoarthritis is considered to be the risky of thrombotic complications due to instability of the cap of the plaque located in cartilage region. The patient might become progressively more inactive, leading to morbidities in relation to decreasing the physical activity, including potential weight gain, and sometimes the risk of fracture, especially in the women population having the high risk of systemic osteoporosis, can be seen in the patient population. So that primarily all this profile is defined at the fragility of the patients. In some cases, the fragility is defined as the global risk of the premature death in this patient population. So on next slide, you can see the history of osteoarthritis. Let's give me a chance to clearly explain in which way and which extent all the some histories compound can be incorporated at anamnesis of the patient with osteoarthritis established by the physician. So first of all, pain. The pain and the global interest of physician, because the main reason of the complications of the patients having the established diagnosis of this disease, and the pain is the global complaints that apply for the physician when the first meet the patient. So the pain is the main reason the patient seek medication attention. Some profile of medication, including non-steroid anti-inflammatory drugs, analgesics, including non-steroid analgesics, behaving inappropriate and non-safety, the out of the safety profile in cardiovascular safety whatsoever. So, and the pain being the main reason, the medical attention requires being treated with some drugs which can have specific safety profile. And so some patients initially being symptomatic might be turned into asymptomatic and the treatment with non-steroid anti-inflammatory drugs. So be sure all of the pain must be a main compound of the fragility of these patients. Please check whether the patient had pain previously and the heart today, and what kind of non-steroid anti-inflammatory drugs and analgesics require, and how many taps can be used to completely solve these patients and improve quality of life of well-being. Because of non-steroid anti-inflammatory drug in the majority given to these patients might lead to worsening of potential fatal risk and induce the complication and bringing about some negative effect on the cardiovascular risk and the risk of bleeding. Morning stiffness, and the next compound which can be incorporated in the history of osteoarthritis. Really, in routine clinical practice is quite difficult to understand which morning stiffness occurred first. Morning stiffness in skull muscle and the morning stiffness in joints. Frequently, the patient having history of osteoarthritis had morning stiffness in joints rather than in muscle. So the stiffness and time and rest can be developed by the patients being out of the therapies, and sometimes stiffness at the times are not considered to have been the first compound of the complaints of the patients having this history. So that's when we compare the pain and the morning stiffness, that the pain appears to be most common clinical signs when compared with the morning stiffness and the stiffness at times. So joints when become stable with disease progression, but it's the history out of a fairly early stage of the progression of osteoarthritis. So the pain can become more prominent in the fairly early stage, and then Sufficient moving limitation in joint with the completely lost of professional activity and it occurred in the physician is frequently engaged in the precipitating of cooperating with the people to check what kind of compound that the profile and the pain, stiffness, joints, moving limitation, and so on are being most common for these patients. And we should pointing out the prioritized position, which one of the history should be checked out and completely sorted out, and then please identify the target for therapy, the pain, improve morning stiffness, improve stiffness at times, or other complications of this disease. In the next slide, you can see the short list of physical examination which can be applied for the patients in the routine clinical practice. First of all, physical examination findings are mostly limited to affected joints, and you should provide the thorough examination of the people around all the joint using the conventional questionnaires that they called DAS-28. The malenlargement with the body enlargement, depending on disease severity and disease activity, may occur regardless of the metabolic profile. So in the most cases, erythema in the room or the joints doesn't occur. Apart from the situation, then we have potential fatal complications due to infective complications whatsoever. So that frequently the patient having reactive synovitis might exhibit erythema and exert roaring in the joint. But frequently, especially when we have natural course of this disease, like poorly articular variant of reactive synovitis in the patient and establish a diagnosis of osteoarthritis, the roaming completely absent. So the limitation of joint motion, muscle atrophy around of the joints involving pathological process are common for these patients, and the more thoroughly affected joint, the people having local osteoporosis, especially the moving limitation, is frequently found in the people with metabolic condition, overweight and obesity. Not necessity to talk about the people with the morbid obesity and this link with movement limitation in some joints due to the pressing and the completely destroying of the narrowing in articular space in the cartilage. So that's common for these people with the morbid obesity. So, and today we should focus on the source of the pain of osteoarthritis, since it's quite difficult to understand which one, the compound, might be applied for the people for each clinical situations. For instance, on this slide you can see the short list of main sources of the pain, and not necessarily to think of the pain due to collapsing cartilage in the main compound of the pain of osteoarthritis and osteoporosis as well. So the joint effusion and the stretching of the joint capsule can be seen in this patient, especially fairly early stage, when we have the mismatch between the pain feeling and physically obtained proof of osteoarthritis in these patients. And this stage of the natural evolution of the disease, the capsula can involve in pathogenesis fairly early than compared with cartilage. That's why the term name is seen destroying of cartilage out of this process at the early stage in the pain is closely related to the stretching of joint capsula. Next source is referred to increased vascular pressure subcortical bone. Frequently, we can see the close link between the development of osteoarthritis and the follow-up in closer connection with cardiovascular disease and risk. The profile of cardiovascular risk includes systemic osteoporosis hypertension, especially in the senior patients. So that finally increased vascular pressure subchondral bone is closely associated with arterial hypertension, the cellular dysfunction, and sometimes the barometric pressure can lead to increased vascular pressure in subchondral bone and thereby contribute to a pain feeling located in the appropriate zone around of joints, the rheumatic pathology process. Atonement is the next compound that lead to occurrence of inevitable pain in the patients with osteoarthritis, especially when lateral horn of atonement being completely destroyed can induce the debris located in the capsula, and thereby it brings about continuously occurred the history of recurrent inflammation and osteoarthritis associated closely with reactive synovitis. So that's finally, please take into consideration the tone ministry and being destroyed is the main compound that leads to in the consequence with recurrent reactive synovitis. What's more, inflammation in the periarticular bursa, especially when we are talking about the knee, the main compound of the pain of osteoarthritis, the inflammation in periarticular bursa of knee, it's difficult to firstly identify manually. In this case, please be sure of using the STAR method of visualization to provide differential diagnosis. What kind of source of the pain can be noticed in the patient as a primary reaction of the early stage of osteoarthritis. MRI instead of X-ray exam is recommended generally for these purposes. Periarticular muscle spasm, the next compound which can be noticed in the patient. Indeed, in majority population of these patients, muscle spasm is considered to be the major factor contributing to recurrent pain around the joints, especially when they have the coincidence of the periarticular bursa destroying and back pain. In this case, please be sure of periarticular muscle spasm requires being completely sorted out, and then using the specific drugs, the mild relaxants being applied for these patients might give incredible effect after even the first dose given orally. So, psychological factors. So it's interesting to know that psychological factors are considered to have been the second compound which can be applied for the decision making for these patients having a recurrent pain, because the threshold level of pain can decrease sufficiently during the long period during the which the patient has been meeting the pain. So that's finally psychological factor, some depression. It's extremely important to point out because underlying mechanism of psychological factor through the BDNF, the brain factors that contribute in the trophic effect in the brain lead to deficiency of some substance in the central zone of hypothalamus and thereby lead to a decline in a threshold level of pain. Finally, all these factors related to each other can be seen in these patients having osteoarthritis. And the last factor is called crepitus. Crepitus is regarding the most common factors that are frequently known, and the crepitus and the rough and the crunchy sensations may be perpetrated due to active and the passive motion of the involved joints, especially in the large and the moderate joints involved in these processes. And the crepitus is easy to identify for the first meeting of these patients. and please be sure that never use the crepitus as the primary initial sole mechanisms leading to pain. Frequently, in the majority cases, the crepitus must be associated with other factors contributing to appearance of the pain of these patients. So my advice, please be sure that the crepitus must be coincident to psychological factors and the muscle spasm, tendency destroying the stretching of the joint capsula. Of course, if no, the active accumulation of the fluid into the free space of the joints, it's called the active synovitis. So, and the next compound, which is absent on the slide, is the frequent complication of the patients after intra-articular injection of the septic arthritis. So our efforts to improve clinical situation about the pain and the completely sorted out through using hyaluronic acid being tuned into the space of joints can lead to the specific complications, infective complications. So they show that these diagnoses require being provided immediately, and evacuation of the fluid is recommended generally to provide differential diagnosis between the source of the pain with accumulation of the fluid and bacterial complications to avoid missing the very life-threatening complication like septic arthritis. So let's move on and turn into the causes of osteoarthritis. Commonly, the risk factors such as age and obesity and maternal sex are considered to be the global factors that lead to higher risk of osteoarthritis in general population, independently of their ethnicity and the genes predisposition. The chronic trauma infection, especially repetitive occupational trauma, and the patient having some priority in occupational activity, along with the genetic factors in the history of inflammatory arthritis, including seropositive and seronegative arthritis, can be noticed in the next compound, which can be useful to be the cause of osteoarthritis as well. So that finally we can see how the patient with osteoarthritis, the new disease like rheumatoid arthritis occurred. And the contrary, osteoarthritis can be noticed in the patient having primary diabetes, rheumatoid arthritis, non-specific arthritis, seronegative arthritis, ankylosing spondyloarthritis, so on. So that finally the history of inflammatory arthritis is incredibly important to provide the differential diagnosis between other types. So the arthritis and the sort of non-specific arthritis can be noticed in these patients. So to finally be sure that the wide range of the causes of osteoarthritis must be prevented, and these ones can be identified thoroughly to improve clinical status, well-being, clinical quality of life. And the two next compounds which may accumulate and very important causes of osteoarthritis are considered to be neuromuscular disorders and the metabolic disorders. There are no point in arguing that metabolic disorders such as type 2 diabetes mellitus, morbid obesity, and the systemic vasculatory process due to neuromuscular disorders, as well as other diseases that include the contracture Duchenne, for instance, and the myopathy Duchenne, can be seen that this patient is the primary reason in the onset of arthritis. So that finally accumulating the knowledge, you must be confident that the wide range of the causes required from you, being sure that all causes from this list that you choose from, and please, and your routine clinical practice, you are welcome to tick over nearby age factors that you accumulate your knowledge and they provide you clear clinical recommendation to improve survival of these patients through completely solved out of these cases. So next slide depicts pathogenesis of osteoarthritis, depending on the staging. The staging is a natural evolution of this disease, is accumulating our knowledge of these general principles of the enrollment in this process. Some cells, the so-called antigen presenting cells. So on the slide you can see how antigen presenting cells being involved in translocation of some signals between them, induce the accumulation of pro-inflammatory changes into collagen matrix and the so-called extracellular matrix. For instance, the primary accumulation of T cells and antigen-presenting cells like macrophage and mononuclears through overexpression of pro-inflammatory genes, something like genes for pro-inflammatory interleukins, including interleukin 2, interleukin 1 beta, interleukin 6, and also tumor necrosis also alpha can be under-stimulation of T cells with the loss, the completely suppression effect that comes from Th2 dependent T cells. So that's finally the overexpression of pro-inflammatory cytokines lead to infiltrative changes in extracellular compound, and thereby in the turn lead to decline the number of the chondrocytes. First of all, we should discuss about rearrangements of collagen matrix, which is under full control of our expression of the so-called MMPs. It's clear abbreviature that are called as a matrix metalloproteinases. Matrix metalloproteinases are involved in a rearrangement of cartilage, and the hepatocytes induce the overexpression of some MMPs like MMP4, MMP6, MMP9, which destroy cartilage directly. So that finally the osteoblasts, being counter-stimulation of overexpressed pro-inflammatory cytokines like interleukin 6, can stimulate the osteoclast and thereby lead to destroying the not only subchondral bone, that including usuration, and the shape that's called the pro-inflammatory matrix. All these processes lead to destroying the cartilage and occurrence in the free space of the joints, the so-called cell debris. Debris are considered to be main triggers that support and maintain the follow-up inflammatory changes and thereby lead to accumulation of the fluid. Moreover, the debris they can stimulate the T cells and thereby the circle the end up. And finally, we can see that the mesenchymal stem cells being under control of anti-inflammatory cytokines can suppress, and the lower activity of endogenous repair system can not maintain the reparative potency of chondrocytes. And so finally, we can see that the products of cartilage break down the phagocytes, but the synovial cells can lead and bring about the release of even more the inflammatory cytokines, and the apoptosis of T cells are completely absent because of genes predispositions. Finally, we don't exactly know in which way these apoptosis can prolongate negative impact of Th1 dependent mechanisms, leading to the tissue degeneration and the occurrence in the cartilage and the pro-inflammatory products, including some products that comes from pro-inflammatory changes, the oxygen potency. So finally, these general principles elucidate in which way the chondrocytes can be destroyed and the cartilage lost the potency to be reactivated and repaired. So that finally reactivation of the endogenous activity of osteoclast is considered to have been the main trigger that contributes to the specific mechanisms associated with the occurrence in the subchondral bone, the specific degenerative compounds. So that's finally on next slide. You can see that short explanation that etiopathogenetic of osteoarthritis depending on the stage. And the first stage, proteolytic breakdown, you know, that MMPs, for instance, the cartilage matrix occurs. The proteolytic breakdown is the result of the overexpression of pro-inflammatory cytokines that are independently released on the wide range of the cells, including macrophage, mononuclears, and antigen dendritic cells. The chondrocytes metabolism affecting leading to an increased production of enzymes, which includes metalloproteinase that destroy the cartilage matrix and lead to occurrence in the stroma of the so-called cells and out of cell debris. The chondrocytes and debris can lead to prolongation of the proteolytic breakdown. Next compound is referred to the chondrocytes accumulation is produced protease inhibitors, and this stage is the adaptive mechanism, but the strength of this mechanism is incredibly suppressed by some overexpressed pro-inflammatory cytokines, and the process can be inhibited by metalloproteinases 1 and metalloproteinases 2. Stage 2 is closely related to involvement in this process of fibrillation and erosion of cartilage surface, with the subsequent release of the proteoglycans and the collagen fragments, the synovium, being incorporated in synovial debris that support inflammatory changes and lead to accumulation of the fluid into joints. And the last stage, the stage 3, it's associated with the same process, being the consequently reactivated, the process lead to breakdown further and brings about the product of cartilage and induced the chronic inflammatory changes in response on synovial degradation. A synovial macrophage product of cytokines including interleukin-1, tumor necrosis factor alpha, and metalloproteinases occurs and the support the prolongation of and deluge of pro-inflammatory changes located in synovium. All these can diffuse back in the cartilage, directly destroy tissue, stimulate chondrocyte to produce more metalloproteinase. And finally, these events alter and they get devastating effect on the joint architecture. And the maladaptive mechanism are over-exceed an adaptive mechanism. The finally, this cannot stabilize the tissue reparation and lead to destroying the cartilage in the subchondral bone and thereby the ending up of the pathogenesis of osteoarthritis. So what about the lab studies which can be applied for as the mandatory component of the examination of the patient with osteoarthritis, all being expecting adults who had osteoarthritis as well. So unfortunately, no specific lab abnormalities which can be associated closely with osteoarthritis. There are no clinical data associated with the specific lab reports apart from the active synovitis with the link to increased high sensitivity reactive protein exists. So that's why the acute phase reactants and the erythrocyte sedimentation rate are not elevated in the patient out of reactive synovitis. So finally, these lab studies are not recommendation when they have no clinically resoundingly proof of reactive synovitis. By the way, this is some synovitis cannot be established manually and require to be identified with some methods of visualization. Because of nerve roaming frequently around the joint involved in the pathological process, synovial fluid analysis is recommended generally to provide differential diagnosis between the kind of types of reactive synovitis in the patient having osteoarthritis or combination osteoarthritis plus rheumatoid arthritis or gout plus rheumatoid arthritis plus reactive arthritis, or the other combination can be seen. So this finally synovial fluid analysis usually indicates that the blood cell count, predominantly lymphocytes and neutrophils, less than 2000 per milliliter with a mononuclear predominance. So this phenomenon fluid analysis is frequently absolutely normal in the patient having the simple reactive process as a result of reactive synovitis that came from osteoarthritis, but not of reactive arthritis with infection reason or rheumatoid arthritis. What's about imaging studies? Imaging studies are generally recommended to identify first whether the patient is a candidate for some deep understanding of the mechanism, the pain or involvement in the process of the periarticular soft tissue. Secondly, what kind of diagnosis should be noticed for this patient as a primary and secondary? Third, which one of these patients can be elucidating and having the risk of the progression of the disease? And finally, the imaging studies are recommended generally to provide to clearly elucidate the stage of the disease, So that the final X-ray or so-called radiography is recommended as the initial tool to certify the patient at risk and obtain the more clear information about the staging. So please conduct imaging studies on the affected joints as soon as possible to certify the patient at risk and clearly elucidate whether the patient is a candidate for other procedure. Frequently you have been involved in some consilium with the aim of elucidating whether these patients might have the combination of some disease, including osteoarthritis, rheumatoid arthritis, osteoarthritis, and reactive arthritis, and so on. And the fairly early stage, that MRI is better when compared with radiography, because MRI can help you out to identify the fairly early stage of enthesitis, ligamentitis, and other process located around of ligaments in the fascia. So other findings include asymmetric joint space narrowing, subchondral sclerosis, subchondral osteoporosis, and the cyst formation. It's critically important to identify whether the cyst formation is the primary process or it's the result of the secondary associated closely with the accumulation of some metabolic acid like uric acid. So that frequently we can see how the can coincidence the patients with osteoarthritis having these findings, including symmetric joint space narrowing, subchondral sclerosis, and plus the accumulation of the crystals at the nearby the final layer of the cartilage. So that's why it's critically important to provide differential diagnosis between both diagnoses, and mainly it's extremely difficult that it seems to be. So extraradiographic findings are often poor predictor of the degree of symptomatology in the periarticular patient having the primary osteoarthritis because of diabetes mellitus, morbid obesity, and other metabolic condition can mask of the properly effect of the passive and active movement limitation whatsoever. So be sure of the X-ray should be provided after MRI at the fairly early stage to improve the sensitivity and the specificity of these imaging studies. So, and in the conclusion of the slide, please be sure that MRI at the fairly early stage might have priority when compared with the X-ray, but X-ray remains the prominent investigation to provide the X-ray staging for these patients. So on this slide, you can see the schematic representation of natural evolution of osteoarthritis from fairly early to advanced stage. And the first stage, we can see the minimum distribution of the tangents and the not rarely clinical condition where we cannot see of this patient any changes in the narrowing and the periarticular tissue also. And by the way, it's regarded to X-ray exam only, but not for MRI. MRI, the plank for these patients might have priority, and frequently we can see how in these patients MRI can help us out to identify the subchondral osteoporosis and the cyst formation, but X-ray didn't. So, and the next stage is clearly characterized by the cartilage, a breakdown and the accumulation of the fluid in the synovium. And the joint space narrowing is frequently associated with thickness of the cartilage, and sometimes we have the usuration and the cyst formation can be seen. So the modular joint space reduction on the stage 3 is frequently associated with the gaps in the cartilage, and all these proof can be clarified clearly at this stage, and be sure all this stage is completely unsolved, regardless of the methods being applied for these patients you choose from. So, in the advanced stage, clearly characterized the cartilage destroying, and frequently we can see the ankylotic process. And so on this stage, we can see and completely disappearance of the pain, and for these patients, this disappearance is properly associated with severe movement limitation, being these individuals incapable. So on the next slide, you can see the good example on the real X-ray findings reflecting severity of osteoarthritis. So we can see that arrows indicate that the specific findings that comes from the X-ray. Please be sure we can see that the A figure subchondral osteosclerosis, subchondral osteoporosis, and osteophytosis, which can be applied for the stage at the stage A to B, at the early to moderate stage, So the next one, we can see the narrowing of the fissura on the stage 3. And the C figure, the clearly illustrate these findings, and comes from the well illustrating the process. In the stage 4, which come from that figure D, the good illustrative compound in the advanced stage associated with complete movement limitation due to destroying of the cartilage as well. So, and below the bottom picture depict the osteoporosis, osteosclerosis, osteophytosis, and the so-called osteophytotic changes of distal phalanx of the fingers. And we can see that the peripheral distal process having a symmetrical pattern. Please provide the clear distinction between symmetrical patterns in distal and the proximal joints. At distal symmetrical patterns is the best fitted for osteoarthritis, in the contrast to the symmetrical pattern at the proximal joints is closely associated with rheumatoid arthritis. On the slide, we can see CT findings of osteoarthritis. And we can see very decisively the osteoporosis, the local osteophytosis, and destroying of patella with usuration, and this stage is classified as a 3. And this slide that clearly explains the cyst formation, the fairly early stage in the patient having a severe movement limitation, the patients with the so-called mouse in the breast, and the occurrence suddenly is the compound of the debris coming down from the destroying the cartilage, and that lead to extremely fluid accumulation being the part of the natural evolution of reactive arthritis. So these both figures illustrate clearly that our priority and the superiority of MRI finding when compared with X-ray at the fairly early stage, and give us and some priority to find out more information in the proof on the diagnosis at the fairly early stage, when we have some obstacles to clearly understand in which stage our patient is. So on the slide you can see the general principle and reduction of joint stress in the improve well-being and quality of life. Let's illustrate this position into 4 general principles. First of all, instruct the patient to avoid aggravating stress to the affected joints. Secondly, please provide him clear implementation of the correction procedure and the patient illustrate poor posture. Beforehand, please provide the clear illustration that the changes of the posture of the follow-up prior to the checking of the risk of osteoarthritis. Don't forget about examination of the posture. Next general principles is associated closely with an encourage so that this patient or the patient having the so-called dramatic and the morbid obesity to lose weight. This is taking the stress of the effect these on the hips and to prevent them from totally destroying the cartilage. Be sure of the knee and the hip and the stage 3 to 4 is clearly considered to be the major factor contributing to premature death due to fracture in these bones. So, and some occupational adjustment might be necessary, and please inform the patient about the risk of occupational repetitive trauma that affect the joints and is considered to be in the main compound of the pain that this patient in the turn brings about in the fairly early manifestation of the clinical signs and symptoms characterized with all osteoarthritis and osteoarthrosis. So physical therapy. So starting with this slide, we should focus on the main principles. How can we treat this patient? The physical therapy is considered to be the best tool to improve well-being and quality of life of the patients. Based on our knowledge up to date, so your knowledge and the physical therapy is considered to be the specific tool that can be applied for the patient having moderate joints involved in the process. First of all, the knee and the hip. So in osteoarthritis of knee, diffuse atrophy and the quadriceps may occur, and this muscle help protect the articular cartilage from the further stress. Instruct the patient to perform aerobic exercise and mass strengthening exercise, that the final effect of them is closely associated with reduce the muscle strength and the muscle strength and the body improve blood pressure into articular structure, and then this process can improve blood flow and prevent the progress of muscle atrophy. Hydrotherapy may be beneficial because of decline muscle spasm. You know, the metaspasm is the main compound leading to the pain of these patients. So some patients find relief with the heat in the capsaicin cream that applied around the joints and the place locally. And all the affected joints, sometimes the aura of periarticular tissue and the soft tissue, it can be quite beneficial. So some patient might find it ineffective, especially we can talk about the people having established osteoporosis. Indeed, osteoporotic-induced pain are absolutely incapable being improved by applying the thumb capsaicin. So that physical therapy is applying for the treatment of the patient having osteoarthritis, but please be sure that some people having some source of the pain, including osteoporotic pain, instead of muscle stretch, the muscle spasm, so it can be ineffective. So what about pharmacological therapy? The pharmacological therapy is quite effective, especially when we talk about the beginning of the therapy with analgesics and non-steroid anti-inflammatory drug. Because of acetaminophen having the optimal cardiovascular profile is recommended generally for the patient having to mild to moderate pain without apparent inflammation. So finally, it's incredibly to know that acetaminophen, the paracetamol, is recommended generally if we have to improve the pain only without a lead to reduce inflammation. So if not so, non-steroid anti-inflammatory drugs are recommended generally. Use the lowest effective dose which adjusted the patients personally, and please titrate up slowly to reach the optimal daily dose and prevent the occurrence of negative signs and symptoms, something like bleeding, the most life-threatening negative impact of a non-steroid anti-inflammatory drug that they follow up continuously taken in. So that the patient with high-resistant pain, please consider the analgesic tramadol and even more advanced analgesics. Muscle relaxants may have beneficial effect on the patient with evidence of muscle spasm, with at least 90% of all individuals having pain due to posture, altered posture, for instance, might have muscle spasm. So for that, please don't forget about incorporating your routine clinical practice these drugs. So contemplating the articular injection of glucocorticoids to improve symptoms. All these drugs are recommended generally, but not more than 4 glucocorticoid injections be administered to the single joint per year because of concern that the long-term damage of cartilage and induce the higher risk of infective complications. Please don't use the systemic corticosteroids to prevent from systemic osteoporotic, especially in the patients in the female population, they having some perimenopausal osteoporotic changes. So, and they prescribe some hyaluronic acid to improve crepitus in these patients. These drugs must be taken in independently in auricular spaces by syringe, and frequently we can use it in 6-month period to improve crepitus and improve quality of life. So, and they consider judicious use of narcotic as with analgesic aim. For these purposes, codeine in combination with acetaminophen can be used generally, and this combination is quite safety and incredibly cardiovascular profile. Create them the main tool to improve relief pain in the majority of this patient population having severe osteoarthritis. And finally, to close the topics in some words regarding surgical care. So on the slide, you can see the arthroscopy, osteotomy, and arthroplasty are generally recommended for the patients with unresolved clinical issue. The surgical care can be quite effective in these patients with the stage 4 of osteoarthritis. So arthroscopy may help patients with osteoarthritis of knee that has specific structural changes on the image. And the frequently cleaning of knee associated with the occurrence of debris and the so-called mouse and the associated with debris in the free narrowing space in the joints. So arthroscopy can help it completely out. So osteotomy. Consider this procedure for those patients who had enlargement of the hip of the knee joints, and arthroplasty can be provided for the patients with other modalities, something like severe decompensate type 2 diabetes, mellitus, morbid obesity, and so on. This procedure alleviates pain and may improve function of knees, for instance, on the hip. Approximately 5 to 15 years of availability are expected on the joints replacement if there are no complications. More often than not, the patients may improve their survival, but this procedure is quite bloody and is associated with the incredibly increased risk of potential fatal complications like pulmonary thromboembolism. Be informed about it considerably, and prior to provide this recommendation, my advice: be sure of prevent this complication with some drugs in the prescriptions. At consultations, and the psychiatrists may help you out with the formulating a non-pharmacological management plan, and the referral to orthopedic surgeon may be necessary if a patient fails to respond to the medical management plan, and the nutritionist may help out with the patients achieve some weight loss to prevent put on weight, especially the patients having morbid obesity in type 2 diabetes mellitus as well. So let's move on to rheumatoid arthritis. This is the topic of our lecture, which can be running out. So, rheumatoid arthritis. First of all, rheumatoid arthritis definition is provided on the slide, and the rheumatoid arthritis is now referred to chronic systemic inflammatory disorders of theoretically unknown causes, without established single causes, that primarily affects the peripheral joints and the symmetrical pattern. It's a potential life-threatening disease with a poor clinical outcome without effective treatment. The frequency of rheumatoid arthritis is quite high. It's approximately 1% worldwide. It quite increased, the number, and during the last decade is mounting up, especially in the South Africa, Morocco, and South Asia. So disease concordance in the monozygotic twins is approximately 20%. Suggesting that the non-genetic factors play an important role too, but the concordance and the both potential aggravating surrounding factor and combination with genes predisposition. What's about morbidity and mortality? Really, rheumatoid arthritis independently cannot lead to death. By the way, rheumatoid arthritis is considered to be the global factors which can contribute to accelerating atherosclerosis, increased risk of heart failure, and the potential thromboembolic complication, infections, and so on. The primary, we can see how the risk of premature death increase depending on the severity of rheumatoid arthritis. After 5 years of disease, approximately 33% of patients will not be working due to the unresolved devastating effect of inflammation on joint moving. But this effect is closely related to the risk of systemic osteoporosis and the pulmonary thromboembolism. Being a life-threatening complication, this condition can lead to increased mortality and the morbidity of this patient having this disease. What's more about causes? So on the slide we can see the combined causes exist. The genetic, environmental, hormonal disbalance and the immunological causes are being incorporated in our up-to-date knowledge. What's about genetic predisposition? In their theory, genetic predisposition can be noticed in the majority of the patients having juvenile rheumatoid arthritis, but not of the patients occurrence of the disease have been incorporated in the middle to senior ages whatsoever. So environmental factors, including occupational chronic trauma, or morbid obesity, diabetes mellitus, other metabolic condition, something like thyroid dysfunction, can be noticed in the global aggravating factor that lead to natural evolution of rheumatoid arthritis. Hormonal disbalance is clearly resulting in the female being involved in continuous observation. During the last 2 decades, it has been clearly understood that hormonal disbalance can be incorporated as the primary cause of rheumatoid arthritis in the patient having genes predisposition. And finally, immunologic conflict is conflict between T1 and Th2 dependent process is considered to be it plays a pivotal role in the pathogenesis of rheumatoid arthritis. So that finally I should emphasize that no necessity to underline only one mechanism, the only one cause which can be applied for the pathogenesis. The combined factors are discussed about them. So on the next slide, you can see some compounds which can be incorporated in the pathophysiology of rheumatoid arthritis. It would be infections, it would be genes predisposition, and some immunologic factors. So, first of all, you should know that in the patient having reactive arthritis due to rheumatoid arthritis, and reactive synovitis due to rheumatoid arthritis, the etiology of this arthritis can be trying to well establish it by evacuation the fluid, and most often than not in there we can have a great opportunity to detect the mycoplasma organisms and some antigens for Epstein-Barr virus infection, and the parvovirus antigens and rubella antigens, and even antigens of human hepatitis C virus. So whether these compounds are confirmed are the ideas making up that maybe these organisms and antigens can be the primary trigger of rheumatoid arthritis. They are not clearly understood today. So, and the genetic compounds, the some epitopes of HLA, DR4, DR1, and frequently the combination DR4 cluster plus DR01 can be associated with the risk of the onset of juvenile rheumatoid arthritis. So, in some immunologic mechanism, something like association of the Th1 dependent process, the amount of circulating CD4 T cells associated with decline the possibility of fibroblasts and the phagocytes to be destroyed by apoptotic process. This immunology conflict plays a central role in pathogenesis of rheumatoid arthritis. On the slide, you can see the key element of pathogenesis. First of all, let's concentrate on unknown exactly primary factors that contribute to initiating of the cytokine nets activity, the overexpression of some pro-inflammatory genes in antigen-producing cells can associate with the overexpression of the cytokines and release them from these cells, with the co-stimulating effect on B cells from Th1 cells. So we don't know exactly in which way Th1 cells cannot suppress and they cannot induce endogenous apoptosis of B cells. But this process play a pivotal role in the co-stimulation of B cells and they preserve the clone of B cells in the follow-up and leads to thereby to overproduction of pro-inflammatory cytokines, something like interleukin 6. So that's finally all these cytokines, I mean interleukin 1, interleukin 1 beta 2, 6, and along with the tumor necrosis factor alpha, being expressed over of osteoclasts can stimulate them and thereby lead to osteoclastic resorption of bone tissue, leading to osteoporosis. By the way, the same cluster of the signature of inflammatory cytokines lead to direct destroying synovium and appearance of granulose tissue that's called panos. Panos is the combination of the extracellular matrix and the signature, or the kind of signature of the cells, including T cells, antigen-presenting cells, mononuclears, and activated phagocytes. All of them can release the pro-inflammatory cytokines and directly destroy the subchondral bone and cartilage, leading to occurrence of the cold debris, which induced the follow-up remittent inflammation. So that in addition, panos can directly provide the powerful devastating effect of the subchondral tissue and destroy both the cartilage and the bone directly, and lead to the loss of the mass of bone tissue. And finally, we can see the combination pathophysiologic phenomenon as well as bone destruction, cartilage destruction, and menstrual destruction. So, and what's more about the regulation of interleukins? The central role of Th17 cells can be seen recently. So these cells is the co-stimulator for interleukin 17 and be under control of some cytokines produced by activated mononuclears, I mean interleukin 15 and interleukin 23. Th17 T cells plays a pivotal role in the regulation of the activity fibroblasts, macrophages, chondrocytes, and osteoblasts. The wide spectrum of pro-inflammatory cytokines and the enzymes and the chemokines and the rankles and the solubilized molecules are involved in pathophysiology of local and diffuse inflammation, the cartilage damage, and the bone erosion. So that finally, why we can know more about Th17 cells, because today we have had new drugs with a target against this molecule. I mean interleukin 17, interleukin 15, and interleukin 23. The Cosentyx and Trimfer. There are recent clinical trials which can be shown that these drugs and agents are extremely effective against natural evolution of rheumatoid arthritis. And today, they are generally recommended being incorporated into routine clinical practice. Next slide elucidates our knowledge about the following criteria, diagnostic criteria, which can be applied for both classification of rheumatoid arthritis and providing the final diagnosis. So first of all, it would be morning stiffness. Morning stiffness occurs in and around the joints in at least 1 hour before maximum improvement. This parameter is quite sensitive because we can check it and provide the continuous monitoring during therapies of the patients with established diagnosis of rheumatoid arthritis. And the shooting period of morning stiffness clearly elucidates how our treatment applies for these patients effective. So arthritis of 3 and more joints areas can be speculated at the major criteria of rheumatoid arthritis, especially when we have the clear proof of tissue swelling or the fluid accumulation. Moreover, you can know that symmetrical patterns of arthritis of hand joints plus the involvement in the specific location of the joints, I mean proximal interphalangeal, metacarpal phalangeal, and wrist, elbow, knee, ankle, and metatarsal phalangeal joints can be noticed in the patients the more properly sensible growth on this arthritis, which can be used in the major criteria that apply for the classification of rheumatoid arthritis. So, along with symmetrical patterns in the arthritis of hand joints, with the morning stiffness pattern, so rheumatoid nodules and the several rheumatoid factors are recommended generally to use in routine to confirm the diagnosis. Rheumatoid nodules is referred to subcutaneous nodules, are present or bony prominence or extensor surfaces or in extra-articular regions. So several rheumatoid factors along with other serological molecules which can be completely available today are recommended generally to demonstrate the seropositive or seronegative variant exists of these patients. You must know that at least 5% of all healthy individuals must be positive according to the serum markers, they called rheumatoid factors. Rheumatoid factors is defined as immunoglobulin G and M against immunoglobulin G, the large molecular size molecule which cannot demonstrate the clear kidney clearance, and the bile can be fixed in the tissue and mediate the peripheral tissue aseptic inflammatory reactions. This reaction is exerted close link with digital vasculitis, which can be frequently observed in the patient with the combination rheumatoid arthritis with the systemic form of this one. So, and radiographic changes typical of rheumatoid arthritis on post-arterial hand and wrist radiographs, which must include erosion on an equipment body calcification, localized in the or most marked in joints in the involved joints. Osteoarthritic changes alone do not qualify because osteoarthritic changes must be located in the distal joints but not in the proximal. But the criteria must be checked completely out, only proximal symmetrical pattern. So this classification had been clinically transferred to EULAR, combined EULAR-ICA classification in 2010. According to this classification, we can have some beneficial improvement of this approach to provide the advanced effect on the classification and the pooling the criteria of rheumatoid arthritis to improve the primary diagnosis. So today we show the calculated joint distribution with the reactive synovitis and swelling, so-called. And then please classify these swelling joints according to pointing out at these thumb points. And the serological markers, including ACPI and rheumatoid factors, can be applied for, and the patients having both might have 3 points, and either or might have 2 points. At the symptoms duration less and more 6 weeks can be provided as having 0 and 1 point respectively. And the acute phase reactants, the CRP or high sensitive C-reactive protein, can be applied for these patients, and individuals having abnormal CRP or abnormal ECR might have 1 point instead of the normal ones having 0 points. You should calculate all these points, and if from 10 points your patient exerts 6 more points, your diagnosis is referred as established. So to easy understand in which way it works, please download in your smartphone the appropriate program, the soft, to easily calculate the total sum of these classification criteria for rheumatoid arthritis. So it's too simple and easy to use in routine clinical practice. If you don't want to upload in your smartphone the program, please use via internet and easy to use and the free access with the site ACR or EUR or both. Next topic is referred as physical examination. On the slide you have the long list of some joints which can be examined by you during this process. Please don't forget the 28 joints must be examined physically, and you should check each of them, and then the complete appropriate questionnaires called DAS-28. These questionnaires have symmetrical pattern, and all of these joints can be thoroughly examined, and both patterns, swelling and tenderness, must be evaluated by a physician. Some other commonly observed musculoskeletal manifestations are tendinositis, and it's frequently associated tendon rupture, and the periarticular osteoporosis due to localized inflammation and generalized osteoporosis due to systemic chronic inflammation can be noticed in these patients. And the immobilization-related changes in corticosteroid therapy are referred as aggravated factor, and being checked out that these factors can be seen in the majority of these patients having rheumatoid arthritis. Moreover, more patients have muscle atrophy due to activity of disease or some severe movement limitation, so that please be sure of checking it completely and provide the final completion of questionnaire is called DAS-28. So what's the effect of rheumatoid arthritis on the organs and the organ system can be seen? So it would be a quite range of organ system, including skin, myocardium, pulmonary tissue, GI, renal, vascular, hematologic, and neurologic, and ocular system. So that's finally, you should look through each system and check what kind of disorders can be noticed in these patients. And then you should verify the stage of the progression of the joints abnormality. Unlike osteoarthritis, the patients having rheumatoid arthritis, we should identify the appropriate staging by X-ray. But on contrary, the complete coincidence with the previous decision making for applying for osteoarthritis at the very early stage, you must choose from MRI but not X-ray to identify the early staging process in the subchondral bone. So that's finally stage 1. It's turns early rheumatoid arthritis. No destructive changes observed upon X-ray examination. On this stage, the frequently stays rated with early phase, the less than 6 weeks after occurrence of the first signs and symptoms of the disease. The X-ray evidence of osteoporosis can be noticed, but it's optional. So, and most often than not, at the stage 1, the patient having very early stage of rheumatoid arthritis clinically must be coincident to, and at this stage, your treatment, the plan for these patients became extremely effective and lead to a reverse of negative changes which can occur in these patients during this period. So the stage 2, the called moderate progression stage. Moderate progression stage is associated with periarticular osteoporosis with or without slight subchondral bone destruction. So the destructive process can be noticed in this stage along with slight cartilage destruction. And the joint mobility possibly limited, but joint deformity is observed frequently. So that the joint mobility and the passive movement can be seen in these patients due to pain. So, but not for ankylosis, but the pain, the main reason to lead to moving activity restrictions. So extra-articular soft tissue lesion can be observed. Is it possible? The findings can be determined as optional. Stage 3, the severe progression. Radiographic evidence of cartilage and bone destruction in addition to periarticular osteoporosis can be seen in this patient via providing X-ray exam, joint deformity, extensive muscle atrophy, extraarticular soft tissue lesion can be verified but optionally, but not generally. So the stage 3 is defined as not potentially reversible. So that finally you should know that stage 1 and 2, the optimal time during which you can provide effective treatment and brings about a reverse effect on the pathological condition. So stage 3, starting with it, the stage 3 and of course stage 4, the terminal progression stage, no great possibility to improve functionality of these patients, and our target is improve quality of life only. So, and stage 4, the terminal progression is closely associated with the occurrence of fibrosis and the bony ankylosis without any perspective to be improved. So, and the next slide, you can see the classification of the functional status of the patient having rheumatoid arthritis. A quite simple classification can be applied for all patients having the arthritis, not only with rheumatoid arthritis and osteoarthritis. So the class 1 and the class 4, sequentially classified the loss of professional or vocational activity, something like that. Class 1, completely able to perform usual activities of the daily living, and the fairly early stage of the patient having acute synovitis and other soft tissue abnormalities without the loss of professional vocational activity. Class 2, able to perform usual self-care and vocational activity, but quite lost and limiting in avocational activity. Class 3, to be able to perform usual self-care activity along with limitation in vocational and avocational activity, which can be noticed of the patient generally. And the class 4, with the severe limitation and ability to perform usual self-care, vocational and avocational activity. These are patients having the class 4 are considered to be inability person, okay? So on the next slide we have to move on the specific classification of disease progression measurements. It's not quite difficult as it seems to be, that so finally there are specific features which can be checked out and they provide the proper reaction of the complete confirmation and the pulling all these data out. So the tender joint count, swollen joint count, patient assessment of pain using the Personal Questionnaire Visual Analog Score Index, patient global assessment of disease activity by means with the specific scoring and a visual scoring system. So, physician global assessment activity of the disease, the patient assessment of physical function, and the acute phase reactant value. All these markers have been incorporated in the logistics scheme, applying for progression measurements. No necessity to sort each phrase out, so you can upload the MAR presentation and look through carefully and thoroughly. And please be sure that the disease progression and the remission criteria should be checked out at each visit of the patients to the office. So let's concentrate on the remission of rheumatoid arthritis. It's the target of our treatment. The 5 or more of the following conditions presented at least 2 consecutive months should be qualified as a criteria of rheumatoid arthritis remission. What's more, duration of morning stiffness not exceeded 15 minutes, no fatigue, no joint pain, no tenderness and swelling, no soft tissue, and ESR of less than 30 and 20 for females and the male respectively. So, by the way, please take into consideration that soft tissue swelling in the joints is considered to be the most important factor, exceeding over others. So when we have the soft tissue in even one joint, it's supposed to mean that patient have never remission, you know? So that's why it's critically important to thoroughly calculate and evaluate each criteria. Being compliant with the score system, this criteria can help you thoroughly out and they provide the clear recommendation for patients. Stop treatment, prolong treatment, reduce daily dosage, and etc. Differential diagnosis. Differential diagnosis is depending on the short list of some diseases associated with arthritis. For instance, infective arthritis, autoimmune connective tissue diseases, other rheumatic diseases, subacute bacterial endocarditis as a compound of the sepsis, and hemoglobinopathies and angioimmunoblastic lymphadenopathy. All these diseases have been previously shown to have mono, oligo, and polyarthritis, and this compound of the right spectrum of the disease must be clearly elucidated prior to provide your clear recommendation to use immunosuppressive therapy, so that a differential diagnosis plays a pivotal role in clearly understand whether the patient is a candidate for immunosuppressive therapy. What's about lab studies? The lab studies, unfortunately, no pathognomic test can be available for this patient to help you out to confirm and rule out the diagnosis. And the markers on inflammation, hematologic parameters, complete blood count, the check of anemia, whether present or absent, hypochromic anemia, for instance, suggests blood count and frequently associated with bleeding. Moreover, the bleeding can be induced by uncontrolled therapies and the intaking of non-steroid anti-inflammatory drugs. So, moreover, anemia can be a result of the drug therapy initially prescribed to the patient to reach and remission of the disease. And the thrombocytosis and thrombocytopenia can be seen in these patients due to different causes. Thrombocytosis is a common, it is also associated with disease activity, especially prior to prescription of DMARD. On the contrary, thrombocytopenia may be a rare adverse effect of the therapy and may occur in the patients with Felty syndrome. Because of Felty syndrome is closely associated with chagrin, and all these conditions require being treated with the glucocorticoid therapies given as a system, the TAPs or intravenously given. So leukocytosis and leukopenia can be seen, but leukocytosis may occur but in unusual and severe activity, usually mild activity. Leukopenia may be consequence of therapy of the compound Felty, and frequently the DMARD therapies, especially very aggressive DMARD therapy, can lead to leukopenia and neutropenia associated with the high risk of bacterial complications in these patients. To produce differential diagnosis with a septic process and gout-induced arthritis, and especially when acute headache exists, synovial fluid analysis is generally recommended. And inflammatory synovial fluids, you can see the blood count on the slide. We usually use the neutrophil predominance in the patient having the established diagnosed rheumatoid arthritis. But no other compound can be seen, especially crystals, when compared with gout acute headache. So note that because of transport defect, the glucose level, the pleural pericardial synovial fluids from the patient with rheumatoid arthritis are often low compared to serum glucose levels that are frequently low twice when compared with circulating level, for instance, 4.4 millimole per liter in peripheral blood and 2.2 in synovial fluid. Immunologic parameters include rheumatoid factors, anti-nuclear antibodies, and the possible other newer antibodies, anti-CCP and anti-RI33 can be identified the patient's synovial fluid also. Moreover, sometimes we can see the patients with having the negative profile for RF and the anti-CCP in peripheral blood, but the positive after checking and serological markers obtained from synovial fluid analysis. For both cases, should be provided the different diagnosis. If your patient exerted the positivity from the anti-CCP and RF, regardless of the source of the obtained results, peripheral blood of synovia, these patients must be qualified as seropositive. Okay. So the rheumatoid factors. So the rheumatoid factors is present at approximately 60–80% of the having rheumatoid arthritis or the course of their disease. And frequently the concentration of rheumatoid practice can be fluctuate irregardless of DMARD therapy, the non-necessity to produce the continued monitoring of rheumatoid practice with the aim of elucidating the positive response of the drugs, no necessity to do it, please. So other antibodies, including ANA, anti-CCP, and anti-RNA3, are defined as phenotypic antibodies, which cannot be applied to the continued monitoring of the patients to check whether your patients are positive responders of the DMARD therapies. So what kind of biomarkers is something like anticyclic citrullinated peptide important, the prognostically important for the patients? Really, this is at least 95–97% the specificity for rheumatoid arthritis exists for these antibodies, and about 20% of rheumatoid arthritis patients are seronegative, but they can be positive for anti-CCP, and more often than not, the physician must be informed about the powerful prognostic impact over positivity to anti-CCP antibodies in the blood, because all these patients exerted higher activity of rheumatoid arthritis when compared with those who had no anti-CCP positivity in the blood. So, what's about imaging studies? Imaging studies qualified as radiographs, MRI, sonography, bone scanning, and densitometry. At the fairly early stage, MRI is recommended generally, but at the moderate to severe stage, please use X-ray as traditional element to the stage and checking, and please use a radiograph of lung when needed. So sonography and the bone scanning can be used to distinguish inflammatory from non-inflammatory changes of these patients, especially when reactive synovitis suddenly occur in the female in the perimenopausal period. Don't forget about the risk that having the malignancy induce reactive synovitis. In this case, please use X-ray and MRI sonography and the post scanning to clearly understand whether the risk of the malignancy exists, and the tumor can be seen frequently in these patients. So, and densitometry is not really applied for these patients, but densitometry with the aim of elucidating systemic osteoporosis exhibit low specificity in the sensitivity, and today we have another method to improve our knowledge about these findings. So on the slide you have the typical findings obtained the patients having established rheumatoid arthritis. On the slide you can see the destructive process associated with subchondral osteoporosis, usuration, and the tendinitis and vaginitis and ligamentitis and the all spectrum tendons exerted. So, and moreover we can see the deviation of the distal phalanx and involvement in symmetrical pattern the proximal phalanx at the visit card of these patients to be qualified as the clear diagnosis exerted. So, the next slide, histological findings. It sounds strange for the patients, but in reality, histological findings can help us out to provide differential diagnosis in the patient having the risk complete on lymphoma, the non-Hodgkin and the Hodgkin lymphoma, and other lymphoplasma cystic infiltration. It is sometimes it's so difficult it seems to be because the manifestation of 10% of the patient having non-Hodgkin lymphoma can be run in monoarthritis. So on the next slide you can see that principles on non-pharmacological therapy. Please be sure that education, physiotherapy, occupational therapy, and orthopedic therapy can be applied for all these patients. By the way, without education principles, I absolutely sure you don't have the clear effects in the survival of the patients and reduce the risk of natural evolution of rheumatoid arthritis. Please don't neglect the education around the patient having the established diagnosis. So, the last slide depicts the pharmacological care with DMARDs. DMARDs is classified as disease-modified rheumatoid arthritis drugs. Which can be divided into two groups, the xenobiotic and biological agents. The first of them, xenobiotic agents, I mean the galsols, the penicillamine or copridine, chloroquine, sulfasalazine, methotrexate, azathioprine, cyclosporin A, and bufluramide can be incorporated there, and biological agents might have been provided into routine clinical practice if you absolutely know about the target. For instance, TNF blockers, something like etanercept, might have the receptors, solubilized receptors for tumor necrosis factor alpha. Chimeric antibodies against TNF alpha, like adalimumab and infliximab, might have dramatic positive effect on the short-term outcomes, but their positive effect on long-term outcomes is not quite resembling from methotrexate, for instance. Other drugs incorporated as biological agents in this group are anakinra. This is chimeric antibody against interleukin-1, Actemra, chimeric antibody against interleukin-6, tafasitinib, the antagonist of genus kinase 3, and abatacept, the selective co-stimulator modulator that inhibits T cells activation. So, how does it work? You should choose from the one xenobiotic agents. Properly, it would be methotrexate, 5 to 10 milligram per week, along with folate, the same dose, and add-on to the drugs, the one biological agents. More often than not, it would be tofacitinib or Actemra. Actemra is usually recommended for patients having juvenile rheumatoid arthritis. So the most important combination, the playing the pivotal role in reaching of full control for natural evolution of rheumatoid arthritis, that the combination based on methotrexate plus tofacitinib, the effectiveness of this combination is about 98%. So properly you can use the double combination methotrexate plus tofacitinib, and please add non-steroid anti-inflammatory drugs and other compound of the mentioned above treatment. So, and you have 6 weeks to reach full control for disease. Otherwise, please modify the treatment scheme, remove one biological agent and add another one. And sometimes you can switch methotrexate to cyclosporin A or sulfasalazine. And frequently we use methotrexate or cyclosporin A in the combination tafasitinib, anakinra, or anti-interleukin-6 chimeric antibody Actemra to reach full control for the disease. So the time is over. Our lecture is over too. Good luck and bye.